Good afternoon, everyone, or good morning, depending on where you are. Thank you for joining us today. My name is Meg Schneider. I'm the program coordinator for the TOR program at the National American Indian and Alaska Native ATTC. And I want to welcome you to today's webinar. Contingency Management, what it is and how it works in SUD treatment. Before we get started today, we have a couple of housekeeping things to get through. As I'm sure you're all aware, the National AIAN ATTC is part of a network of a number of ATTCs around the country, and it's one of two national.
Click on those or what?
Well, my volume is not on. They can probably hear me because I myself.
Okay, Davis is muted now, so. So we're one of the two national ATTCs. The National Hispanic and Latino ATTC is the other one. We are supported by a grant from the Substance Abuse and Mental Health Services Administration. And our disclaimer is that the content of this event is the creation of the presenters, and the opinions expressed do not necessarily reflect the views or policies of SAMHSA, HHS, or the American Indian and Alaska Native ATTC. Following today's event, you'll receive a follow-up email, which will include a link to the presentation slides and the recording, information about how to request and receive attendance certificates, and a link to our evaluation survey, which we also will put in the chat at the end of our event. The survey is very important for our funders and to ensure that our events are relevant and useful to those who attend. And we really appreciate you taking a few minutes to help us out by completing the survey. We also do this at every event that we have, although we are meeting virtually today. We want to take time to acknowledge the land and pay respect to the indigenous nations whose homelands were forcibly taken and inhabited. I'd like you to take a moment to read our land acknowledgement. This was created by three members of our team, Ella and Keely Driscoll and Sean Bear, who are all members of the Meskwaki. Ella and Keely also have Winnebago Nation background. And before I introduce today's speakers, I want to acknowledge the people who are in the room with us today. We have a couple of people from SAMHSA. Will Longanetti, would you like to introduce yourself and your team?
Oh, sure. Thanks, Meg. Hi, everyone. Thanks for joining us. I'm Will Longanetti, and I am a project officer on the TOR grant. So it's good to see you. I'll pass it to Brittany.
Hi, good afternoon, everyone. Thanks for joining us as well. I'm one of the other TOR GPOs on the team. Not sure if Paul's here. If he is, I'll pass it on to him. If he's not on, maybe he's joining later, but Paul is other GPO on the team, so we're all here represented.
Okay, thank you.
Thank you.
I don't know if we have anyone other than Parker from the ATTC. Parker, would you like to wave and introduce yourself?
I'm Parker, Communications Coordinator, and I help with tech support. So if you have any questions or issues, feel free to message me and I can help any way I can.
It has been our custom before we get into the business of our meetings to ask for volunteers to provide a blessing or an opening, something to get us started in a good way. If anyone feels comfortable offering that kind of opening blessing, we would be grateful to hear it. Kathy, do you feel like you'd like to offer something for us?
Peter, please allow our hearts and minds open as we review this material today. Please allow our spirits to join with each other in sharing as well as taking in. This is a topic that may not fit spiritually, but would fit in other ways. So open our hearts and minds, Creator, to the learning and allow us to share with each other today. Thank you. And I'm sure somebody could do a better prayer than that, but sometimes a few words is enough.
Thank you, Kathy. All right. Kathy is one of our speakers today, as I mentioned earlier. And our other speakers are from United Indian Health Services in Arcata, is that correct? California? They gave an overview of their entire TOR program at our regional meeting last week, but they also have found ways to incorporate contingency management in sort of an informal basis. And so today they'll be here to tell you how they got started and how it's working for them and what their plans for the future is. And I'm sure they'll be very willing to answer questions. We have with us today Amanda Colgrove and Chelsea Castellioni. Did I pronounce it right this time, Chelsea? I butchered it last week. Okay, so with that, I am going to turn it over to Kathy.
Well, I have a few slides to go over, but before I begin, I want to thank Meg and Parker because they've had a really busy summer. And I hope I don't cross boundaries, Meg, but Meg's recovering from a bout with COVID, and she's a trooper for being here, not feeling always on her game. So thank you for both of you for being here. The other thing I want to mention is this topic. I mentioned in my offering, this topic is an interesting one in the sense that it works within Native communities, and it's not necessarily consistent with all the values within Native communities. So I'm going to present you an overview, a very brief overview of what contingency management is. And then we're going to ask you to think about your tribal communities or your treatment programs or wherever you're working, and think about how you might see this working within your treatment or service structure, but also what thoughts you have about integrating more Native spirituality and approaches into this concept. With that being said, think about that. Like, how do you envision this working within your systems based on the definition of it? And there's I've heard of a lot of incidental stories from Native communities where they have been using contingency management successfully. So I'd be curious to hear those stories too. So I'm going to move over to the PowerPoint that I created for this. And I'm going to go to slideshow. All right. So the topic is how to use this with alcohol and other drug use disorders. For those of you who are more holistic in your thinking, you could also add physical care, you could add mental health care into this, but the focus will be on alcohol and other drug use disorders. Okay, so I'm going to start with some definitions. What is contingency management? And I'm going to literally read to you what I found. This is a definition that was found in several articles that I read regarding this, but I'll paraphrase it somewhat. So number one, contingency management is a behavioral therapy. So behavioral therapies don't necessarily add in how a person's feeling or their past history when they're trying to affect a particular behavioral outcome. So it is a way of reinforcing or rewarding particular positive or desired behaviors, which is defined by either the agency or, depending on your situation, the courts or the person, and by reinforcing through rewards. And then if the behavior isn't being shown, then punishing the negative behavior. So when you think about that definition, you might want to think about your setting and what might work in that setting. The other thing I'd encourage you to do is, as I was preparing this, I was thinking about how this particular approach would work within my own personal life and how it's worked in my own personal life. So you may have heard the term motivational incentives, and contingency management was renamed as motivational incentives, particularly as motivational interviewing came out in terms of doing target behavioral interventions for alcohol and other drug use disorders. So contingency management has been pretty well researched in alcohol and other use abuse treatment. And here below are some of the targeted behaviors that were researched: alcohol and other drug use, improving treatment attendance, and then reinforcing other treatment goals such as medication compliance, getting a job, completing your treatment plan goals, or completing treatment plan goals within a certain time frame. So what is this based on? So it's based on this term called operant conditioning, which is a term used in behavioral therapy for reinforcing and punishing consequences to alter the form and frequency of voluntary behavior. The original research was way back in the 60s, 1960s, whereby they did animal studies, and then they generalized the animal studies to human subjects, and they found similar outcomes. Alcohol and drug use is considered the operant behavior, the behavior that you want to affect. And the research indicates that there are biochemical effects of abused substances, and by reinforcing the emotional, the social reinforcement from peers, and also some of this early research was done prior to the 90s when the brain science came out. So, what are some examples? One of the early research studies was trying to affect what they call public inebriates, people who were maybe on the streets, intoxicated. This is prior to the homeless epidemic that we're having right now. And they were finding that if they rewarded certain behaviors to keep people from being publicly intoxicated, that there was a reduction, and didn't reward in a blind study, and didn't reward or punish, that they found those who were rewarded for decreasing public intoxication fared better than those who received no neutral response or a negative response. Reinforcing, it works really well with adolescents, and I believe that is because of the nature of development with adolescents. Adolescents' brain development doesn't allow for abstract thinking, particularly when they are affected by substance use disorders. So behavioral treatments and cognitive behavioral treatments tend to work really well with them. It was found to reduce alcohol consumption with schizophrenics, alcohol and drug medication compliance, treatment attendance, and going to other meetings like probation, and completing personal and other treatment goals. So part of the structure for applying contingency management is based on the structure and what would be rewarding within that structure and what would be negatively. The example I think of is methadone maintenance. If you follow the rules of the methadone program, you can earn your way up to take homes, and you can also, if you don't follow the rules, that privilege can be taken away until you get back into compliance. So here are some principles of cognitive contingency management or motivational incentives. So if I'm going to develop a program that would use this as an adjunct to already well-known approaches, this would be my thinking. This would be how I would think about it. So what is your targeted behavior? Contingency management works best, and so does motivational interviewing, works best when you have a specific targeted behavior, such as compliance with treatment or the behavior of buying or using substances. Secondarily, it's really important to identify who your population is. Who are the type of people that would benefit the most from this approach? For example, it works, as I mentioned earlier, really well with teenagers, but it may not work, or maybe people who are adjudicated, but it may not work so well with someone who's already highly motivated. Then in my thinking, what are the best reinforcers? And this would mean that you consider from your population what they would consider to be a reward, something that is both desirable, but also that the program can realistically afford. Frequency, again, based on the resources and what's practical. How much does a client need to stay engaged? How much reinforcement would they need? Past use and success, strength of social supports in response to rewards. So from my knowledge of the patients, clients that I'm working with, what are they telling me would be the frequency of reward? And that would be different from one patient to the next to the next. So the frequency ideally would be individualized. This is a rewards. It's sort of like rewards with having a conversation with somebody. When you want to learn from each other, getting immediate feedback is important. Rewards work the same way. Best delivered when you see the behavior, when the behavior is actually occurring, allowing for a strong link between doing the behavior and rewarding the behavior. So that's something to think about, is in the context of how I'm working with somebody, what's the likelihood that I could reward that behavior and see that behavior and then offer an immediate reward. Now, when you think about elementary school, how many of us went to elementary school where we got stars or little attaboy, attagirl kind of comments from our teacher in a classroom setting, and if you earn enough stars, then you get a special reward. So that's an example. And how long to offer the reward depends how stable the behavior that you're targeting is once the reward is removed. And then also with substance abuse, what happens with relapse prevention? So you wouldn't remove something that's keeping somebody abstinent if that's their internal or external motivation, unless you could pretty much guarantee, and they can guarantee to you that they're not going to relapse, or that they have a pretty good relapse prevention plan that will work for them. So here are some variations, and this is, you may hear this more often than not. Voucher programs are very common in substance abuse treatment programs. So what that means is that you get a voucher of different levels of value based on increases in improvements of your behavior over time. And those vouchers can then be traded in for items such as food or a limited amount value credit card, concert tickets, entrance fees to activities. In some of the Native programs that I've worked with and heard, getting some beading materials, so they have ways to do beading, getting materials to make something, being able to participate in a particular activity, being able to lead a particular activity, being free to go to certain activities that might have been high risk for them, things like that. Prize incentives are offered like a negative urine, medication adherence, attendance to treatment, etc. And the more that the better is the person is doing, the better chance for higher value prizes. Prize incentives can be expensive, and so you have to consider your funding availability for prize incentives. But it could be that people share in tribal communities different goods that people offer, and that they would be able to pick from particular goods that they might want to earn enough points, if you will, to be able to get the gift, like a handmade medicine wheel or something like that, some form of art. So here's some thoughts, some additional thoughts. You want to consider environmental issues that foster positivity, so it's seen as a positive approach. Reduces any ambiguity, and ambiguity arises when the target behavior is unclear, or the peer support system isn't supportive or half supportive. And then also the person's engaged with the helper. in the sense that there's a positive working relationship with the pollster or the person. Most often you're going to see in alcohol and drug programs, you're going to see contingency management incentives used in concert with other approaches or in combination with other approaches, such as motivational interviewing, cognitive behavioral therapy. I added trauma-informed care because I think that from a Native perspective, you want to look at the effect of trauma, the behavioral effects of trauma, and you want to be able to have that alliance to move into this approach. And then anything that naturally reinforces culturally focused approaches, which is something I added as well. So some of the adjunct, or it's an adjunct to some of these other approaches, counseling approaches, are researched and found to be supportive, and others are not. So that pretty much covers what in the time frame what I have. I just wanted to show you some references where you can go do a little more research if you want to do a little more research on. There's a lot written about contingency management, so I included the web address and also the National Institute for Drug Abuse, the National Institute for Alcohol Abuse and Alcoholism, National Institute for Health, and of course SAMHSA, and our center is also a reference point for you. Any questions? Okay, there's nothing in the chat box. And my thought, or my wondering is how many of you are already doing this, and even if you're not formally doing this, does this make sense to you? Are you feeling like, okay, well, there's things that I'm doing that I hadn't thought about as incentive programs, as opposed to the more formal incentive program where you have money attached to it or funding attached to it or more structure attached to it. Anybody doing that? I was more curious than anything else. Okay. I then will turn it over. Do I turn it over to Chelsea and Amanda, or what am I doing?
Yeah, Chelsea and Amanda have done some informal contingency management, and we invited them here to talk about how they got started and what kind of incentives they're offering and how they're working. So Amanda and Chelsea, start wherever you would like.
Sure, sounds good. Thanks, Meg. And thanks for that, Kathy. That's really good overview information. I was taking some notes, and I think that, yeah, the more I just kind of like look at it, trying to look at it from different angles and wrap my brain around what it is and how we can continue to implement it, it's been really good. So really appreciate that. Hey, young everyone, my name is Amanda Colgrove. I am our Health Promotion and Education Department Manager at United Indian Health Services. I'm a Hupa tribal member, descendant of Hupa, Yurok, Creek, Quinault, and Cherokee Nations. And yeah, I'm fortunate that I get to work for a clinic that serves people of this area in Northern California. We service clients of our clinics in Humboldt and Del Norte counties. So we get to kind of serve a lot of the Native people who are in our county, which is great. I think it's an honor to be able to do that. Chelsea, you want to introduce yourself as well?
Absolutely. Hi, everyone. I'm Chelsea Castellioni, and I am the Health Promotion and Education Supervisor for our Tribal Opioid Response Project. I'm relatively new, been here for about 6 months, but it's been really great to be able to come on under Amanda's leadership and be able to work on the Tribal Opioid Response Grant and work on harm reduction efforts in the community.
Thanks. Yeah. So this is the work on this is for a TOR grant that is in our HPE department. And so we're able to operate kind of under our tribal public health division. And when I came on for the tribal opioid response, just working with a grant basically and trying to figure out what that would look like in our clinic, how it can best serve our departments. And I think one key thing that when I think back on trying to put this together was we were meeting, or I had a couple great meetings with Katie Bell from Telewell, and she was able just to give me some really like great pieces of advice of just basically looking at the integration of the different departments and how things can work for the betterment of all. And so we do have a medical department here, and we also have a behavioral health department here, and they have different approaches to what OUD and SUD look like, not conflicting, but just they do different things, right? So the medical side of our opioid side will provide the medication assisted treatment, the MAT program, and they have clients who are working through that program in different steps. And then our behavioral health side also has the counseling component to it coming alongside, and they have different ways of working through their steps. And so one of our first things I think we did just as a TOR grant was just get kind of everybody to the table and start communicating with each other about what everyone's doing. And then also, because we have these funds of how basically how can we best support each of the different departments. And so we're kind of sitting here with like, well, we have some funding and we have some objectives that we have to do, but how can we best support the people who are already working with our SUD and OUD clients? Because they're kind of, you know, the medical providers and the behavioral health counselors are at this point like in between us and the people who we want to serve, which is our clients. And so, which we do outreaches and stuff, we do get to see clients in general, but as far as contingency management, if that was going to fall on anybody, it would fall on these two different departments. So we just kind of basically took what we could do, providing incentives or support with anybody who's going through recovery, what that could look like in their different steps of recovery. And we just kind of start setting up meetings with our departments, our medical department, behavioral health department, and just ask, what can we do for you? This is what we have. This is what we're able to do. How does that work with your department? And so through some of those conversations is where some of these things with incentivizing started coming up. And, you know, for instance, talking to one of our behavioral health counselors who work with OUD clients, he said they were having, you know, some, they were hoping to get, they're having people who are coming and they're doing really good with their opioid use disorder. But they also were maybe needing some encouragement or some sort of push to really, when they're doing their drug tests and their screenings, to like not have, as they say, like to reduce meth or other substances. And so just looking for ways that maybe we could encourage that. And they already have some of their programs, excuse me, set where when they first come in, maybe they see a doctor or a counselor like on a weekly basis. And so they have these steps where if they have so many, come back with so many correct tests, and they're able to go and see counselors maybe less, maybe it jumps down to like every other week or once a month. And so they already have these like kind of stair-stepped programs that they have on both the medical and behavioral side. So we kind of just looked at that and said, well, what if every time they go from one step to another, we're able just to kind of provide an incentive and a, hey, good job, here you go. And so we just started looking at things like that. And and that's pretty much what kind of where it is. And I think Chelsea has some information about like more about like what we're doing tangibly day to day or week to week. But we've looked at doing even a more formal contingency management plan and looked at getting some different funding for that as well. And so during that time, I reached out to one of the main medical providers who brought the MAP program to our clinic and asked her, hey, how would this work for you? Are you familiar with contingency management? Would it be something you'd be interested in? And she said that it was really good timing, that she had just had one of her providers come back and talk about a different clinic who provides these incentives and contingency management, and said that it's done really well for people in our area. So people in our rural Humboldt and Delaware County area, they've had some really good results. And so because of that, she was interested. So because she's interested, now I'm interested. And so now Chelsea and I are starting to look at what we can do to formalize this, and what that would look like with just even like being, they're going to be in clients' charts and they're going to do reporting. And so we're just starting to look at what the structure of that could be if we are able to do that. And so moving forward, we just have more to learn. But yeah, Chelsea, if you want to talk about what that's been looking like for us with our different departments, that would be great.
Absolutely. Thank you, Amanda. Yeah, so we provide the resources to the departments, and I think we really try and honor the relationship that our providers have with their clients. So our SUD counselors, our behavioral health providers, and they know what their clients like, right? They are meeting with their clients, they're getting more information, they have that greater connection. So if someone, so like right now we provide gift cards, and then the behavioral health counselors get to give those away in a manner that they see fit. And so we listen to their feedback on what the clients want. So sometimes it's like Starbucks and Subway and Amazon. We try as much as possible to get things from local folks and local businesses, but if that's not really rewarding to the client, then it's not going to have the same effect. So listening to the clients in terms of what they want and what they would like as a reward, and then the behavioral health providers and the providers are rewarding behaviors that they want to see more. And I think that they have that individualized relationship with their clients, and so they can reward what they deem appropriate based on the goals, based on the group, based on where they're all at. And this is this is separate from other incentive programs we might offer or other supports like bus passes that we offer. This is, that are just, this is more just to reward different things like sharing in a group, or maybe coming and attending all the meetings or things like that.
Have you gotten any feedback, Chelsea, on how it's working?
Yeah. Do we have that quote from Robbie?
Yeah.
Any chance? Okay.
Yeah. When we were presenting on this before, I just reached out to the counselors and said, hey, do you guys have any feedback on basically exactly what you said, Meg, thanks, on how this has been going, or what that looks like for you. And so it was great because she immediately sent that day back an email real quick. It just had a list of things that she said. And so I can read. She just said, yeah, it has helped us with increasing client attendance. When the incentives came out, one of the clients had a 66% attendance. And after we started the attendance incentives, they increased to 91%. The clients are more engaged in Red Road because they have their own books and study workbooks, which they take home and are able to work on at home. When we go through the 12 steps again, they can see their growth by rereading their old answers. It also gives them a sense that they are important because they get to keep their books. So far, nobody has lost their books. Sometimes they forget, but have never lost. So some of this is outside of contingency management, but she just gave us feedback, I guess, on what TOR's been doing for behavioral health. The clients have a sense of worthiness to have programs built for them and to have funds written in for them, especially with new peer support work we're doing. The class with highest attendance is beading, and we have been able to teach them the peyote stitch and working in round wrapping. Soon, other traditional regalia tool making, which they always desire cultural teachings. We use the incentives to get them to take healthy risks and do a presentation to share recovery stories with peers. Clients share what activities we've been doing in aftercare, such as silk screen, wood burning, gardening, and others want to graduate and become a member of aftercare. We have had 4 new members this year. Last year we had 2.
That's pretty impressive for an informal program. Albert wrote in the chat, a culturally integrated contingency or incentive management for tribal community is how we are improving outcomes. Would you like to expand on that, Albert?
Kachi, Hiyama, Kanyasas Albert Titman. Yeah, absolutely. So I don't know if Katie Bell is in this training, but Katie Bell is a good friend of mine, also a colleague, and together, while we worked at Tellewell Indian Health, we were developing culturally integrated approaches for medication-assisted therapies or medication-assisted recovery programs. And one of the pathways of care included contingency management or incentive management. We went back and forth and discussed how that would look culturally. And, you know, when I worked at the Sacramento Native American Health Center, we had developed culturally integrated approaches to gifting. And so gifting being a tradition across cultures, across many tribes, is its traditional practice, sign of respect. And so we, Katie Bell said, why don't we develop a contingency management program? Let's title it the gifting program. And so it hasn't been rolled out yet, but it's highly effective. And so when, you know, in contingency management programming or planning, when we are somewhat rewarding our relatives for a specific goal achieved, for example, a negative UA or 5 consecutive negative UAs, then they would earn a specific cultural gift, maybe a beaded feather or a necklace, you know. And in our classes, we culturally integrated approaches in the Red Road program. Participants will actually work on native jewelry or different native items. And so the idea is that you could earn culturally centered gifts or the gifting program throughout their care, pathway of care. And so far it's been really effective. So in a nutshell, that's it. Of course, you know, you build it into treatment plans, you screen, you assess for that. But if you want more information, I could put my information in the chat.
How long have you been doing this?
Well, we were at Tellewell Indian Health since 2018. So we began the process then, and then sharing that with programs literally for the past year. Contingency management has been around forever.
Mm-hmm.
And so I've been implementing that concept for 20 years almost. But in terms of now, especially with medication assisted therapy, the Red Road program has been around for a long, long time, and gifting has been a part of that. You know, incentives management or contingency management. We just didn't call it gifting at that time. We now, as we're developing pathways of care for medication assisted therapies for opioid use disorder or alcohol use disorder, or now STEM, people are recognizing it. So I would say we've been calling it that for the past year, but we've really been practicing it at SNAC for many, many years.
I really love that. I love that it highlights the gifting component of it.
When we first started at SNAC, we used feathers, right? Beaded feathers. And so turkey feather, then hawk feather, and maybe, and you know, every tribe is different. So you have to really work within what the protocols of your tribes are. So you have to know what tribal community you're working with, all the way up to an eagle feather, right? Kind of like coins in recovery. You get a coin for your 30 days, 60, 90, 6 months, 1 year, and multiple years. It's along the same idea of that. And then it evolved from that. Anyway, that's my 2 cents.
Thank you.
Thank you for giving me the opportunity to share.
Thank you for sharing. I especially like the point that, you know, word choice matters, and particularly in different cultures. And contingency management is a really clinical term. Yeah. And most people, I would assume, do not respond well to clinical terms. So I really like the gifting program. I really like that terminology for this. And I would imagine it resonates more with your clients than contingency or incentive management would.
I agree. And, Katie Bell, she's just amazing. I love Katie. And, in our discussions, she said, why don't we call it the gifting program, Albert? That's so in line with, culture and what our practice is, traditional practice. And in our discussion, especially around, anti-stigma or anti-stigma campaigning, we say things like words matter, because words do matter. They really do matter. And working within tribal communities, I'm not going to say it matters more, but it matters. And you're right. Sometimes the clinical language can present a barrier for some, not all, but for some. And when we use language that, let's say we were working with another targeted group, demographic, is that we would want to speak to that demographic and be careful not to be, biased or implicitly biased, use stereotypical language, but so a word like gifting that speaks to a lot of people, and tribal people especially.
I also love incorporating the idea of people who are in recovery or helping contribute to it and being the creators of some of the incentives.
Yep.
I think that's great. And I noticed that just when we were looking into, we're trying to do a Sweat House project here too. And when we're looking into that, some of the people that we're going to ask to help teach, rope making or different parts of the plank shearing are also some of our clients. And so it's great to see that there's such cultural knowledge that's packed away in some of the people that are going through our programs, that being able to kind of let them have a platform to showcase that seems to be just a really healing way to also reach people, and then being able to give out to the community. This is really affirming for them and great for everyone else who gets to learn from them. So I like that. I like that a lot.
When I worked with young adults and teenagers, food was a big incentive for them. Many of them were hungry, and when they came in, we had food for them, and like an after school or a late in the afternoon treat. And the combination of having food available and talking to a counselor seemed to work to reinforce not only food, but also within the context of a positive, supportive relationship, where it was a little bit more informal. So there was some disclosure that happened that probably wouldn't have happened in a more formal setting. So that was some of and also one of the counselors had a candy drawer, and the kids he packed one of his desk drawers with candy, and he asked the kids, have you had lunch? Have you eaten today? Because a lot of the young people with substance use disorders have poor nutrition. And so he would open the candy drawer and have a variety of different types of candy that they could pick and choose from. And the kids would eat the candy while they were talking to him. Now, some people might say from dental care perspective, that's not such a great idea, but it's something that kids really, they would come in and immediately open the drawer, and then they would stay for the meeting. So yeah, so from that perspective, especially if you have somebody using hard drugs, it was pretty successful.
Some of the things that y'all said kind of reminded me of a program that we're going forward with based on the recommendations of one of our amazing behavioral health counselors. And it's kind of related to contingency management, but not fully as much in line. And so, Albert, you mentioned the coins, and I'm really glad you did, because one of our behavioral health counselors had this idea of creating coins that had symbolism with local significance and local cultural significance, and utilizing a local artist to develop those coins. And so to make someone feel extra valued, they're getting this, they have this accomplishment, we've got some incentives for them, and then they're getting this token, this like thank you, this us showing them their value and appreciating their hard work in something that's truly is an art piece and also reflective of local culture. I thought that was such a cool idea. She came up with that, and we're starting to go forward with it and find a mentor for these and all of that. And so I'm really, thought that was a cool, interesting take on it.
Yeah, that's a great idea. One of the ideas that came from some of the participants in our Red Road program are that as we were creating necklaces for folks that completed the cycle, their first phase or second or third phase, they received a necklace, and participants made the necklaces. One participant beaded a coin and made it into a necklace. And so we brought a beaded coin in a necklace, and then we said, "Hey, can you make enough for everyone?" And we'll. So he ended up getting compensated for it ultimately as he graduated out of the program, but thought it was a great idea. And if you are interested in some culturally centered coins, White Bison Incorporated, it's an organization. I'm a trainer, facilitator. They develop curriculum-based interventions, culturally centered curriculum-based interventions working with tribal communities. But they actually sell coins. So they have metal coins, but they also have some new wooden coins that are really beautiful. So go to whitebison.org and you can look in their store, and they have some really cool coins, and they're colorful. And they mark, of course, milestones, 30, 60, 90 days, 6 months, multiple years. And every coin has its own color. They're beautiful.
Has anybody had any experience where you were providing negative reinforcements using a contingency management approach?
I kind of have some feelings that like maybe society provides a lot of negative reinforcement, so maybe we don't necessarily need to, because there is so much stigma and shame. And I feel like, and I can't speak for all areas, but I feel like here we're trying to combat stigma so much that we are ever like cautious and reticent about potentially contributing to that. And so I don't know, but I know that we don't particularly do like a negative here.
Yeah, I think go ahead, Albert, sorry.
Oh, go ahead, finish your comment, because you may be already speaking to what I'm going to say.
Well, I'm thinking about a MAT program where you would, if you're having relapses, or you're selling your methadone or your Suboxone to somebody, that you would lose some privileges within that program as a negative reinforcer to doing that, which is consistent with contingency management also. And it's not, I think having Chelsea, I think having that alliance, but also with substance use disorders, it is experiencing the negative consequences of your choice making. So from that perspective, it could be helpful, but you'd have to be careful how it's done.
Yeah, absolutely. No, that's exactly what I was thinking, Kathy. And in our treatment programs, and we're talking specifically,
Yes, ma'am.
MAT, there's a program agreement, right? You have your treatment plans, but you also have program agreements. And in these agreements are embedded the contingency management programming or planning, and negative reinforcement is a part of that. So it's not necessarily stigmatizing, demeaning, but it really is helping folks take accountability, be accountable and responsible for their part of their healing. And so if someone, for example, is in phase one and they're not meeting, right, the goals or the objectives, they can't transition to phase two, right? So you're in phase one as a result of maybe you're not attending X amount of classes in 12 weeks, for example. You're absent, and then you show up. You know, where we don't want to shame them, but at the same time, we want them also to be accountable and be accountable to that. And so you don't get to transition up to a phase two, and that's just one example. But I know it's close to noon, and I have other examples. If you want to take down my information, we could talk about it.
Yeah, that's a good point. I mean, I guess I don't think of that necessarily as negative. When you say it like that, I realize that's negative reinforcement, but it just feels like a more fluid thing maybe, because I know on the medical side for Matt, and then also on behavioral health side for their clients there, they move through different phases. They do go from phase one to phase two, and it all is like, whether they're here, you know, every day or every week, or there's different times and different titrations, even with medications, what that looks like in each phase. But it does feel more fluid. And I think maybe it's the way that they've been able to framework it here, that like, it's just, you're moving from phase to phase, and maybe you go back to a different phase. And that is the negative reinforcement, but it's definitely, yeah, I guess it doesn't feel so negative. It doesn't feel so stigmatizing when it's just
because the other side is incentive management, right? So for example, you get 3 negative UAs in a row versus 3 out of 5, right? You just frame it however you feel is appropriate for your population. So we could create a standard. I think that would be helpful.
True.
We have about 30 minutes left in our scheduled time together. Thomas brings up an interesting point in the chat, and I do not know enough about the topic to know the difference between a punishment and a negative reinforcement. Perhaps someone who has more experience in that could explain the difference.
I'd be happy to talk to that if I have a minute. I'm Tom Fries. I'm the co-director of the Pacific Southwest ATTC located in at UCLA. And I think the language of contingency management is really, really important in that some of the stuff we've been talking about before as non-contingent reinforcers, like a candy drawer, really important, but not contingency management. Contingency management is an all positive intervention in which you display a behavior and you get a reinforcer for it. And positive reinforcers are things like vouchers or the feathers that Albert was talking about, those things that you give someone that moves you in the direction of repeating the behavior. A negative reinforcer is actually taking something away to increase the likelihood of a behavior. So a fee reduction, for instance, would be a negative reinforcer. You're making the cost of that treatment less expensive so that you increase the likelihood that they'll continue to take advantage of that treatment. Or, you know, in the classic experiments, they used to shock animals' feet, and then when they did something right, they would take the shock away. So the shock going away was actually reinforcer. You're removing something noxious in order to increase the likelihood of behavior occurring. A punishment is adding something noxious as a way of trying to decrease the likelihood of a behavior. So taking someone down a step is actually saying you're not doing well, so we're going to move you to a lower step. In essence, that gives them a higher level of service that they need, but we wouldn't consider that a negative reinforcer because it's not taking something away to move them toward the behavior. The language is concrete and specific in CM, but what we always want to do is think of it as a forward-moving, all positive intervention with no negative elements in it at all. So if they don't achieve a behavior, we want to encourage them to achieve the next behavior as opposed to punishing them in some way or taking something away. If we're doing that, we're doing something, but it's not contingency management. I hope that helps.
Thank you.
No, that helps a lot, Tom, and 100% in agreement with that. There is already a standard when it comes to CM, but I hope that helps, Kathy. Does that help?
I think that it's what the problem that I have with it culturally is how the person receives it. That's the problem. And I think that the having the therapeutic alliance is, from a cultural perspective, is even more important, because how somebody, especially a shame-based client, how somebody receives something is really, I mean, there's an internal process that goes on separate from the actual behavior. And it's just like Chelsea and Amanda were talking about, from a cultural perspective, and I didn't see a lot of research on trauma-informed care with contingency management, but I'm not thinking it wouldn't work. I just think that we have to do some more thinking about it because of the trauma that Native communities experience and the fact that it's easily triggered. And so how do you address that within a trauma-informed approach? And I think that we have to be careful with it, although I do think that it's very effective. So I think thinking about it from that perspective, like you're talking about already, I think you have to give that some more consideration. And it varies from person to person to person. There is no like one thing for everybody necessarily based on that idea of, okay, what kind of trauma is somebody experiencing? Just me even bringing up a reward. You know, what kind of trauma might they feel if they don't get the reward and their peers are, and are they talking about that? And how do they feel when they're not able to reach a certain, I don't know, a certain behavioral outcome that's expected? What's the dropout rate related to that? Those are some of the thoughts I have. I'm not an expert. Obviously, Thomas is more expert than I am, but I just think that there's some really strong complements to this, but then we have to consider culture and we have to consider the role of trauma in these programs.
I was going to put into the chat a reference for an article done by Washington State University. The author's name is Herchek, and they did a culturally adapted version of contingency management specifically for Native people called the Honor Program. And they did a series of focus groups, and the article that I was going to, I don't seem to be able to chat for some reason, but the article that I was going to post specifically talks about the methods that they used in order to be able to make sure that the incentives that they were using were specific and relevant to the tribes that they were working with. Her last name is Hirchak, and it was published in JSAT if you're interested in it. I'd also be happy to share the link with any of the organizers if that would be helpful. I think it'd be useful for this audience.
I think I have found the article and we'll post the link. Tom, if you're able to click on it and make sure it's the one you have in mind.
Unfortunately, I can't even see the chat. I'm not sure what's happening with my Zoom today, but I don't have any access to the chat whatsoever. But it should talk about focus groups and cultural adaptation of contingency management. And if Herchek is the first author, I'm sure it's the one.
The abstract, the objective is determine whether a culturally tailored contingency management intervention targeting alcohol abstinence resulted in secondary effects on cannabis use.
Cannabis, yeah.
Oh, that's a different article.
Okay. Let me continue looking.
It's focus groups to increase the cultural acceptability of a contingency management intervention for American Indian Alaska Native communities. Catherine Herchek is the Hirchak is the primary author.
Tom, if you want to send me the link through Teams, I can post it in the chat on your behalf.
Awesome,
Oh.
thanks, Julian.
Sure.
And hi, Albert.
Hello.
I think this is the one you're
Good to see
referring to.
Can you pull it up? Meg?
Sure.
There it is.
And I did put the link in the chat.
Yeah, that's it.
Sorry, I was on mute. Yep, that's it.
Okay. And being the little bit of geek that I am, I want to read this one and the first one I pulled up.
The work coming out of that group and the honor program that they did, that's what they called their contingency management program, is honor. And it's an acronym that is really beautiful, and I can't remember exactly what it is right now. But there's lots of interesting cultural adaptation work that they did, particularly around CM for alcohol among tribal people. So I think there's lots of potential reads in that reference list.
It's a great resource. Thank you. Do we have any other questions or comments on what's been presented so far?
Yeah, thanks for that discussion. There's, I think, a lot to think about when you apply evidence-based practices within Native communities. And consistently what I hear, whether it's a motivational interviewing approach or it's cognitive behavioral therapy, whatever it is, there's a lot of adaptations that go from tribal community to tribal community to tribal community. So even, and then of course the research is pretty sparse within, because it's what, 574 federally recognized tribes, not to mention tribes that are not recognized by the federal government. And so programs doing research that globalizes or generalizes it to all Native communities doesn't necessarily work within tribal communities. So one of the things that we have to learn is, how would your tribal community approach this? So some tribal communities serve urban Indian programs as well as tribal lands. Some people are just a particular tribe that is more closed community. Some tribes have, have different customs and approaches and values when it comes to some of these things. So it's helpful to have some reference, but it's also important to think about your own community and how your community would respond to an evidence-based practice. And what I continually hear from Native communities is, what value do my cultural practices have within this evidence-based practice? And so practice-based evidence. And the research is just, it takes money to fund all of that. And the research is not as full as I think that we would like to see it. And participatory research is ideal, but it takes money to do that. So the best we can do is offer the information and then ask you to think about your community and how your community would respond to this, and who are the key stakeholders in your community to involve in a conversation about this. Because you can have an evidence-based practice, but if it isn't adopted and it isn't followed through fidelity, then will you get the same results? That's the question. For me anyway. And then of course, if the tribe can look at how trauma has affected them in this way, how does the trauma, the intergenerational trauma, and oppression, how does that affect any kind of evidence-based practice that you want to implement? And what are your results? So you can do that independently of having money to do research, but I think, to be fair, in terms of equality within healthcare disparities, I think it's fair to say that you're the driver in your community, and you have to decide, who in my community do I need to involve that could help my community and help the people in my community recover from substance use disorders? Who are the shakers and movers, if you will? Who are the leaders? What role does the tribal council have in terms of implementing evidence-based practices? And so those are always the questions I have whenever I enter into an evidence-based practice discussion, whereby I already know going in, it's not going to be translatable necessarily. So like even what Thomas is saying, if there is a cultural language, what's the word for negative reinforcer? What's the language for positive reinforcer within that community? How would that language interpret that idea or that concept? So those are some of my thoughts about this. It's additional, and I'm kind of on a soapbox about it, but I just want to really support our Native people in a good way.
The cultural considerations are so important. And also because when we talk about evidence-based, I think you're muted, Kathy. But when we talk about evidence-based, the evidence, the people, the subjects of the research that is evidence-based often do not include or do not delineate Native people. And that's why the cultural aspect, culturally informed evidence-based, trauma-informed evidence-based practices are so important.
Absolutely. I agree, Kathy. You made some great points. And practice-based evidence is really important. And then you lay that on a foundation of culture, and depending on which tribal community you're working with. Language is important. But community defined, I have found in every community is unique to that community. So right now I'm currently working with, our own tribe and assisting in developing culturally integrated approaches. And some of the information Thomas shared is really, really powerful. You get an opportunity to read through that. There's some great, great information there. I'm in developing contingency management, incentive management, or gifting in the language. And so one of the things we're doing there with the tribe is developing program titles in the language. For example, the title of one of the programs just simply means guiding our families to healing. And that's the name of the program. And so in the language, it's written on our flyers and messages that we send out electronically. But the subtitle is in English versus it used to be the other way around, where the title is always in English and then the subtitle is in tribal language, if we knew what that was. And so now it's really important and it's powerful. We're reaching folks in that community that some of our relatives are saying, it's a miracle you got that person to show up. And we feed them. So you feed them, they will come. And in tribal community, working on the reservation now, potlucking is traditional practice. Whether auntie or grandma or whoever is actually in the meeting themselves, they will bring food and others will show up as a result. Did you know grandma's making her stew? Oh, really? Okay, I'll be there. Yeah. It's really powerful working in the tribal community in that respect. And then, of course, we deliver the clinical approaches on the foundation of culture, spirituality, and ceremonial practice. So we're giving evidence-based information, treatment, programming, but it's laid on the foundation of culture for that community specific. So the framework allows for us to take this information to every tribe, but lay it on a foundation that is defined by that community. So important.
So important. Absolutely. If there aren't any other questions or comments, the federal government is looking at adjusting their support for contingency management. Will, would you like to tell us what's going on in your world?
Yes, I am the federal government. No. So we, if you look at the TOR funding announcements in the past, there's been kind of strict limits on contingency management funding. And, this has just been a huge topic of discussion at the federal level as well. And I know, the people kind of who make decisions are in the final stages of, ironing out the details on how contingency management can be implemented on these grant programs, in a more robust way. I think the limit that we have placed on the TOR grant in the past has been, way too low to really be in line with the evidence base. I think it's something like $75 or $100 per client per year. And so pretty soon, I think SAMHSA will be announcing that we're increasing that limit to something that's more in line with the evidence base. And if you applied for the new SAMHSA funding, you would have seen in that funding announcement, that we're asking grant recipients for more details on how you would implement contingency management. And, we definitely plan to offer trainings to all recipients free of charge in the next couple months. So there's going to be a flood of emails and resources and announcements coming very soon about contingency management. We know that on the one hand, stimulant use is up everywhere, but on the other hand, contingency management seems to be one of the best interventions we have for addressing that. So we want to make sure that, you all who are working on the ground have this at your disposal and can do it in the fullest way. So that's the update, as far as contingency management. Thank you, Meg. And of course, if you have any questions about doing contingency management with your TOR funding, please, as always, feel free to reach out to your project officer, myself, Brittany, or Paul. Thank you.
Thank you, Paul. We have about 8 minutes left in our scheduled time. Do we have any final questions or comments?
Thank you for providing this as a forum for the discussion. I learned a lot from everyone contributing, so thank you very much.
Thank you. I learned a lot too. Unfortunately, I'm not in the position to actually use my new knowledge for real clients, but I really enjoy these trainings because I always learn something new, and it always reinforces how much there is to learn. So I have put in the chat the link to our Gipper survey. Please take a few moments and fill that out for us. If there's nothing else.
I just want to thank Chelsea and Amanda for providing some direction for us in this meeting. We really appreciate you coming in at the last minute. Thank you.
Yes. Will, are you clapping or do you have your hand up? Clapping. Okay.
And
But
thank
also
you for
thanking our presenters. I'm sorry.
Yes. Yes. Thank you very much, Chelsea and Amanda and Kathy, for providing that overview, which I think was very useful.
I also want to thank everyone who contributed. I feel like I love it when learning is like a two-way street like this. I gained so much from this, and I love hearing everyone's perspectives and love hearing everyone's take on things. So I appreciate you all.
All right. Well, I
think we're going to call it a webinar.
I think we'll call it a webinar. Kathy, would you like to send us off in a good way?
No, I don't. I am terrible at this. So maybe we can ask Albert to offer a blessing.
Albert,
Oh, thank you. Come on. Thank you. Thank you. Yeah, I think I feel honored. Thank you, Kathy. Absolutely, I can offer a blessing. I'm gonna say some words in Miwok, and then I'll translate best I can into English. Jocelyn, Konaska, Tewale, Deke Kamo, Tapani, Deke Kamo, Huke, Kakon, Susapo, Jijima, Eleata, Sawana, Wanga, Nixika. So I offer gratitude to the creator of this great earth, to the ancestors of our lands, and to Mother Earth herself for the blessing of today, for giving us this time with our human relatives, with the air that we breathe, with the water that sustains life. We say thank you to our plant relatives and to our animal relatives today for sharing their life with us, teaching us how to be in relationships. And thank you to our presenters today for sharing their knowledge, their wisdom, and everyone in attendance, that you bless the rest of their day and take this good medicine home to their families and to the people that they serve. So we come in a humble way today. Aho. Oh. Wile matak. Thank you. Have a blessed day, everyone.
Thank you, Albert. Thank you, everyone.